The patient population with statin intolerance is a small group of overall patients. It is within the labels of the agents in that it's recommended to use the maximally tolerated statin dose, and that can sometimes be 0 milligrams. In fact, the very first patient I've treated has had CK elevations documented even on rosuvastatin 5 milligrams twice a week. So he was a real statin intolerant patient and is now doing well and has a nice reduction in his LDL when adding a PCSK9 inhibitor on top of ezetimibe is the other agent that he's been taking. And he does not have, he's very happy in not having muscle aches on this combination. So that population is one that we turn to. I think the clinical point of emphasis is a lot of people read about all kinds of side effects, and most of those are actually not statin related, but muscle aches that we have as we're getting older, and I get them myself. So I know that's true, but it's not a statin that is related in most of the patients. In the Odyssey alternative study, in a blinded fashion, patients were randomized to ezetimibe, alirocumab, or a statin, and 80% of the people could actually tolerate a statin. So that's our first step as physicians, is to work with the patient, try and get them onto statin. But then amongst those who can't or get on something but they're still not sufficiently controlled, adding a PCSK9 becomes a good option. This is an issue that was raised with statins based on adverse event reports of the gazillion patients who have gotten statins. It's frankly unclear if it's real or not with statins, but it's been raised as a question mark, and so once you raise a question, it's actually hard to say no. But now across the program, this has been looked at. There's not a difference of alirocumab versus placebo in the label, and so that's noted in the experience so far. But it's something that in theory should take a while to happen if it did, and so this is a point of ongoing surveillance. But so far, it's actually not been an issue overall.